Today, let's talk about neonatal resuscitation. In any resuscitation, time is always life. So, in the first 30 seconds, we need to get a really good grasp of the direction we're going with this newborn infant. So, the first three questions we need to ask is this a term baby? Is the baby crying or breathing? Or is the baby vigorous with good muscle tone or not? If the answers to all these questions is yes, all you do is warm the baby, dry, stimulate the baby, and clear the airway if there are lots of secretions. If the answer is no, you do all of them. In addition, you check a heart rate, because an increase in heart rate is the most sensitive indicator for a successful resuscitation. And where do we check a heart rate? Checking for peripheral pulses in this critical clinical situation is at best unreliable. So the stethoscope or the precordium is your best friend. A better one is a pulse oximeter, and your best one is the 3-lead EKG, which helps you check the rhythm as well. Bulb suction used to be a routine practice at the time of delivery of the shoulders and even during the first 30 seconds. It's not so much now because we know there's a risk of bradycardia during bulb suctioning. But except when there is clearly area obstruction from secretions. So remember, bulb suction, not a routine practice. Remember the risk of bradycardia, but use it if there are lots of secretions that cause airway obstruction. So now we're at the 30-second mark. So what do we check? Yes, a heart rate. If it's greater than 100, you're doing great. You clear the airway if necessary. You monitor the baby with a pulse oximeter. You use CPAP if necessary for labored breathing or in a preemie infant. But if your heart rate is less than 100, this is the time to start positive pressure ventilations. So you start at room air. We'll discuss a little bit about oxygen toxicity later. But you start at room air, or in some instances with a blended oxygen with air with 21 to 30% concentration of oxygen, especially in a preemie. But ventilations have to be at 40 to 60 a minute and effective. You will see ventilation is your lifeline. It's the key to heart rate. So now at a 45-second mark, we have a soft check to check whether your chest is moving or not. Whether your heart rate is improving or not, make sure the chest is moving. Optimize your ventilations if it's not, because the goal is to have at least 30 seconds of effective ventilation before we initiate CPR. If there's one thing we need to learn from resuscitating neonates, it is that the single most important cause of bradycardia in neonates is hypoxemia. Hypoxemia because of ineffective or inadequate ventilations. So that really is the key. If you can't ventilate well, you get hypoxemic and bradycardic really quickly. Now we're at the golden minute of reassessment. What do we reassess? Yes, you're right, the heart rate. If it's greater than 100, great situation for us. 2 thumbs up to the team, great job. We still need to focus though on post-resuscitation care, making sure the baby is still ventilating, still maintaining that heart rate. With a heart rate of 60 to 100, you're doing okay. but not fantastic. Check ventilations. Make sure they're optimized. Use this mnemonic, Mr. Soap, for mask readjustment, suctioning, opening the airway, using an adjunct airway such as an ET tube or an LMA, and using positive pressure. This is critical time. Time not to give up, but keep your focus. Keep your focus on ventilatory technique while improving your heart rate. Less than 60, bad situation. We're not doing well here. It's time to get those dire measures in to revive this patient. Crank up the O's, secure the airway with the ET tube, and start CPR. And like we said, ventilation is so key that we have to do everything in our possible capacity to achieve that. So if endotracheal intubation is unsuccessful, you could try a laryngeal mask airway. But it may not always be the best choice, especially in a smaller sized baby, because it may be a little unreliable. We could argue for this technique in these COVID times, but certainly very questionable in a delivery room or operating room setting. So what is an effective CPR? The two-thumb circling of the hands around the chest is the best or the standard technique right now because it generates higher peak systolic and coronary perfusion pressures more than the two-finger technique. We do it in the lower third of the sternum. The depth should be about 1/3 of the AP diameter of the chest. And it's critical to coordinate the CPR with the ventilations in a 3-to-1 ratio. So you squeeze, 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 you ventilate. There's no squeezing at the time of ventilation. Maintain this synchrony the whole time. And again, at the next 60 seconds of CPR, you recheck, yes, the heart rate. Now, if you have a persistent bradycardic situation, it's time to take out your big gun, the good old epinephrine, through a reliable route, which is intravenous. In cases of a neonate, it's likely the umbilical vein. Try to avoid the endotracheal route or the intraosseous route. There are some situations where a volume loss is known or is suspected, so you treat with a 10 cc per kilo of an isotonic saline bolus, i.e. 0.9% sodium chloride, not lactated ringer, and give it slowly because of the risk of intraventricular hemorrhage in a preemie infant. So these are blood oxygen levels or saturations in a healthy, uncompromised baby. So as you see, the extrauterine normal values reach 80 to 85% or 95% only about 10 minutes after birth. So our targets during resuscitation should align with these values, which means successful resuscitation can start on room air or even a blended oxygen in some situations. We know hypoxemia and ischemia is bad, but so is excess oxygen. There are at least 2 meta-analyses of several RCTs comparing resuscitation with room air and with 100% oxygen. Both of them show increased survival when resuscitation is started with room air. So that is the standard right now. There's also a link of oxidative stress to retinopathy of prematurity, chronic lung disease, infection, leukemia, and free radical disease. Of course, if the baby is bradycardic, after 60 seconds of resuscitation, you have to crank up the O's. Meconium aspiration is a bad thing. Lots of morbidity, lots of mortality, but really, does intubation and suctioning help? Does it change the incidence of meconium aspiration or even mortality? The answer is no. Right now, it used to be a routine practice, no longer. because of several studies that have shown that it does not really help a whole lot. Babies don't really shiver from cold, so don't even try, but we can leave this topic of non-shivering thermogenesis for later. But for now, critical to keep this very low birth weight babies warm because they can lose heat quickly. But we can also get a little too carried away by inducing hyperthermia, which can also be bad. So it's like damned if you do and damned if you don't, but obviously we have to do the right thing. And we can do that by monitoring the temperature through the course of the resuscitation. Other considerations: currently, naloxone has no place in the algorithm. Therapeutic hypothermia for those with neurologic injuries, yes, it's done in specialized centers where there are protocols in place for cooling methods and the right patient selection. Delayed cord clamping has also got a place. There are two key words there. It's for a vigorous newborn, not in a resuscitation scenario, and those with intact placental circulation, which means not placenta previa, not a placental abruption situation. Withholding or discontinuing resuscitation, extremely difficult decisions to make, but still need to be made. Thankfully, we have some guidelines. So, in a situation where survival is unlikely, yes, I think it's clear you withhold. But in a 25-weeker, there's a better chance of survival. So, you continue with resuscitation, or at least you proceed with resuscitation. If you're not really sure if there's a gray area, the right answer, obviously, always is to consult with the family. Even in a situation where you withhold resuscitation, you would want to have a discussion with the family preemptively. Chances of a meaningful outcome is less when you don't have a heartbeat for about 10 minutes or so, so it's best to discontinue at that time. So just to recap, the first 30 seconds or so, initial steps, initial assessment, then reassessment in the next 30 seconds, maybe initiate positive pressure ventilation. After that, you make a decision whether you start CPR or you don't, and you intubate or you don't. And then persistent bradycardia, epinephrine is the answer. No baby is born right now, and no talk on resuscitation of newborns is complete without discussing about APGAR scores and the work of the legendary anesthesiologist Dr. Virginia APGAR. But what was the real goal of the APGAR score? It's really to assess the condition of the infant after birth. It's not used as a marker to predict neurologic outcomes, or to diagnose asphyxia or severity of it, or even to predict mortality. Multiple studies have shown no correlation with these outcomes. And lastly, this is a neat mnemonic to remember APGAR scores. So appearance, whether the body is just pink, or the whole body, or just a central core. Pulse, grimacing, if they're crying, if there's just a grimace activity, if the baby is vigorous or not, just some flexion, and respirations, whether the baby is actually crying or some labored breathing. So based on that, you have a scale from normal, which is 7 to 10, and severe, which is 0 to 3. Thanks for your attention.